First, we'll make sure. Can you guys hear me? Is this on okay in the back? Nods in the back? Okay. I sat in the back a little bit when I was here, but actually my mother is sitting in my seat. Third seat in, second row is where I used to sit most of the time. So doesn't seem like it's already been 10 years since I was here. 50 for you two, so congratulations. I am very honored to be here to talk to you today. When Dr. Lockwood called me and said they were looking for their speaker for the Tinning lecture for Founders Day, I thought, okay, who do I want to recommend? Who do I want to recommend? I thought he was going to ask me for suggestions. So I'm thinking, who would I want to hear speak? And then he asked me to do it, and I thought, are you sure? Are you sure you want me to do it? I said, have I been doing this long enough? Isn't that what I said, Dr. Lockwood? Yeah. Dr. Lockwood, I had the pleasure that he was my doctor when I was in high school here in Kirksville. He kept me in high school sports for those 4 years. I don't think I would have been able to make it through 4 years of varsity sports if he had not been treating my way through. And he put up with my antics too, because I used to raise the table as high as it would go, and I'd be about 2 feet from the ceiling, and he'd walk in and just shake his head. Put the table back down, and I'd do the same thing next time. So as Dr. Slocum said, I'm actually no longer the co-director of the family medicine residency. I now run alone the integrated family medicine neuromusculoskeletal medicine residency in Grand Rapids, Michigan, which is a 4-year integrated program where my residents can receive a board certification in both family medicine and OMM. So I'm just going to talk to you a little bit today, don't worry, it's not going to be long, on the legacy of osteopathy and how things have changed, I think, over the years since Dr. Still first flung the banner, which I'm sure you all know the date of, because we all had to memorize it for tests, right? So I won't quiz anybody, though I was going to quiz one particular person in the audience because I know his brother, but I decided I'm going to be nice, and I'm going to tell his brother that I did not torture him. So I want to just talk a little today about the legacy of osteopathic medicine, the difference we can make as osteopaths, and a few examples of patients that I've had over my short career. Still's vision. I hear my nephew talking. He probably wants to see more pictures on my cell phone of his cousin, I imagine. Still's vision in the late 1800s was he was dissatisfied with his career as an M.D., so he wanted to have a practice of medicine where he could focus more on the whole person, mind, body, and spirit, which I think many forget after they get their diploma. I encounter many DOs out in practice that are MDs with DO after their name. I mean, they don't think differently. It even isn't so much you have to touch the patient, which I think you do, but their philosophy of thinking isn't any different than MDs. So I often ask people, why did you go to school where you went to school? Why didn't you go to the University of Michigan instead of the Michigan State College of Osteopathic Medicine, if you're going to practice the way you're practicing? I think that osteopathic medicine really teaches us how to get at the root of a patient's true issue when they become sick. And part of that is taking the time with a patient to listen to what has brought them to the place that they are currently. I have just a few patients I'm going to talk about. One in particular, I was a resident. It was a 32-year-old male who had had daily headaches for 6 months. He was on disability, couldn't work. First, let me tell you, my whole patient population now is pregnant women and babies. That's pretty much all I do. When somebody calls my office manager / scheduler says, "Are you pregnant? Are you a baby?" Then she can't see you. I have guys in the community that'll say, I'll tell her I'm pregnant if it'll get me in to see her. But when I was a resident, I had a young gentleman who had had headaches daily for 6 months. I had treated him a couple times, and this was one of the hardest heads I had felt in my short time of putting my hands on people. I thought, what is going on? I knew I was missing something, so I started asking him some more questions. He had not had any trauma, as we would think of trauma, but when I dove a little deeper into his history, I found out that his headaches started after an explosion at his workplace. So he had had a blast injury, during which time he saw his best friend die. As soon as he told me that, oh, his head just opened right up. Lo and behold, it was that memory of seeing his best friend die that had locked his head up. Never had another headache again. That's all it took. All it took was to get to the bottom of what the cause was of that in the first place. So one of my biggest pet peeves when I see somebody, oh, you're a chiropractor. No. That's not offense to any chiropractors, but I'm like, no. One of my favorite stories is I walked in to see a probably 90-year-old man in the hospital. He's on the phone with his wife. Honey, I gotta go. The nurse is here to give me my massage. It's like, oh my. So when Still founded osteopathic medicine, in the old books and texts, he was known as the lightning bone setter, because that's what he did, right? He moved bones around. We do that. We can do that, but we do a lot more than just move bones around. We address all the soft tissues, the membranes, the ligaments, the muscles, the tendons, and we can get in there and treat organ systems too. I have a patient named Lydia who I've seen 3 times now. This is just an example of what I think how osteopathic medicine has changed over the years, from working with bones to working with deeper issues. Lydia is an 8-month-old who, her first appointment with me, we have electronic medical records at my hospital. And in the computer it says 8-month-old, flat head, doesn't sleep. That was all it said. Okay, I see a lot of kids with flat heads, no big deal. Sleeping issues, I see a lot of that too. My medical assistant came into the room and said, she's all ready for you, she's in such and such a room. Not another word to me. I said, okay. I went in there, I walk in, baby Lydia is trached on a breathing machine, on a feeding tube, and couldn't move arms, legs, or head. Her head was flat because she couldn't turn her head at all. So I was a little caught off guard because my medical assistant didn't think that was important to tell me. But communication is a big deal. And so I start talking to baby Lydia, and she opens her eyes and looks at me, and this poor little head was very compressed, very flat, obviously, as you can imagine, symmetrically on the back because she just lays all day long. She can't move at all. So they had put her in a helmet, and I found out about the helmet because I asked Mom, when did she stop sleeping? And Mom said, when they put her in a helmet 5 months ago. I thought, okay. Sorry. And she also has more than 10 seizures a day. Let me rephrase. She had more than 10 seizures a day when she came to see me. And I start treating Lydia, and she looks at me, and her eyes roll back in her head, and she just starts to fall asleep. And I'm treating this poor little girl's head, talking to her, and thinking the only doctor she sees poke and prod her. They push things in her, no really nice kind of experience. And I'm talking to her, and she looks at me, and she smiles. And then she starts to move her arms and legs. And her mom goes, did you see that? She moved. I said, mm-hmm. And so I continued to treat Lydia, got her head motion with some motion, which was probably a first for her in a while. And I told Mom I wanted to see what this little baby's body felt like with the helmet on. This baby started to freak out when Mother tried to start to put that helmet on. We got the helmet back on her, and I felt her primary respiratory mechanism again. There was nothing there. And I looked at that mother and I said, don't you ever, under any circumstances, put this helmet back on your baby again. She goes, thank you. And the mom was crying. So they left my office. That was the first visit. Came back for the second visit. Lydia had not had a seizure. She slept 6 hours right after I treated her and had slept a full night's sleep every night since, and was moving her arms and legs more. We haven't gotten her to swallow yet. That's the next goal. But I've seen her 3 times now, and the last visit, Mom and Dad came in together, and I told Mom, I'm very unhappy that I saw on Facebook that you're moving to Nebraska. And the mom said, I know. And Lydia's father looked at me and said, about that, we're wondering how you would feel about flying to Omaha once a month to treat our daughter. I said, I would be happy to if I could get to Omaha. So that's just an example of, when people say, what do you do? Well, we don't just move bones, right? I can get in there, and I told Mom was going to try to calm her nervous system down to try to prevent seizures. Well, she's now probably 60 days seizure-free. So I think that's pretty phenomenal since she was having more than 10 a day. The other thing, you'll find often when you're out in residency and practice that you have to not only distinguish yourself from chiropractors but from M.D.s. Well, how are you different? How many times a day do I have to explain to somebody how I'm different? But I do explain over and over, and I'm proud to explain over and over how I'm different. But I did a rotation downtown Grand Rapids in the emergency room at one of the larger hospitals. We, in residency, have to do a rotation at our hospital, which is now larger because we built a brand new osteopathic hospital in town. But also we have to do a rotation at the downtown hospital. So I'm working with all M.D.s downtown, and I go to see, I wasn't an ER kind of girl, so when a chest pain came in, it wasn't really what I ran to do. For those of you that want to do ER, that would be what you would want to see. I was the one that saw the kids with colds, the vaginal bleeding, all those things, the primary care family medicine stuff, since that's what I ended up doing. But in the ER downtown, they had a lady come in, and they said, Laura, why don't you go see this one? She was an 80-year-old chest pain. She'd been to the ER 10 times in the last 2 to 3 weeks. They had done an EKG every time. They had done x-rays, CTs, bone scans, you name it. They had done it. Do you think they found anything? What do you think it was? Chest pain. What do you think? It was a rib. Who was the first person to touch her ribs? 10 doctors later. And she said, I said, ma'am, it's just a rib that you have out of place. And she said, well, why didn't somebody figure that out before? I said, that's a good question. And I said, who's your primary care doctor? And she told me, and unfortunately it was someone at my hospital. And she said, well, he's a DO. How come he didn't figure it out? Because he didn't touch her ribs. You don't know unless you feel, right? So, or my residents would say, I know when I'm in another room, but that's another story. They hate it, but I come into the room, take your hands off. So this lady, I put her rib back in, and her chest pain went away, and she never came back to the ER again. So that saved a lot of healthcare dollars right there, just keeping her from coming back. We knew it was nothing wrong. She was reassured. She wasn't concerned that it was her heart, so she didn't feel the need to come back to the emergency room anymore. She was okay as long as she knew what the problem was. So, how many of you came to medical school, raise your hands for me, with preconceived idea of what you wanted to do? Like, because you have, so the majority of you really. Well, plans change, and I would challenge you to be able to change with them as they change. I, at one point, was going to be and was actually in an ear, nose, throat, facial plastics residency program. I didn't actually start the program, but I was given a residency spot. I had ideas that I was going to save the world one cleft palate at a time and do things like that. Now I save the world one baby head at a time. And there's a dentist in Michigan that I teach in the Michigan State continuing medical education courses. I teach cranial 1, 2, and 3 with some other doctors, and this dentist teaches with me. And when he's showing pictures of teeth that are, malocclusion and bite problems, he's like, well, we can blame this one on Laura because she didn't treat this patient when the patient was a baby. If Laura had treated this person when it was a baby, this patient wouldn't have had to come see me. And he always says, always tells me that I'm doing the best that I could do to help people down the road by treating them when they're little. And that's part of the reason I do what I do. So I think in terms of choosing your career, we all went into medicine because we want to help people. I think by now people do not come into medicine because they want to make money. Am I right? We know that this is not a career that you do to make money. If we had wanted to do it for money, we would be in business. Right, Dr. Shire? Yeah, it's not about making money. I think most of us would like to spend time with our families and not be working 24/7. I had a lot. I mean, you'll go through fleeting thoughts all the time of what you want to do. The one thing I always told people was, I will never be a family medicine doctor. Guess what I do? I will never be a family medicine doctor. But I decided the only way I could be an OB, pediatrician, dermatologist, OMM doctor was to do family medicine, because I can do whatever I want. I can do just derm and procedures if I want to. I can do just women's health. I can see all pregnant women and babies, which is what I do, and that's what I wanted to do. So, and this little quote is a Chinese proverb that was in one of our fortune cookies from dinner a few nights ago. Doing what you like is freedom, liking what you do is happiness. I think that's a pretty good one. I think most importantly, you guys need to do something in your career that makes you want to get up in the morning, because I did a job for a while that I did not want to get up even on Saturday morning because I knew that Monday morning was 2 days away. Not good. Not good. I'm very happy to say that I love getting out of bed in the morning now. And I think as osteopathic physicians, our most valuable tool of these three, I don't know, but I sure know it makes a difference to put your hands on a patient. I don't do a lot of inpatient consults in my hospital on adults right now because I am currently, only for another month, the only OMM doc at my hospital. My partner moved to Green Bay and left me there to do everything myself. But when we were seeing adult consults and not just babies in the hospital, I had an older gentleman that had had a surgery. And, we see post-op ileus, a lot of post-op things, but he was having a lot of upper shoulder, upper back pain after being strapped to the table like this for however many hours he was on the table. And I treated him one time, and he said right away he felt better. And I told him I would come back the next day, but he must not have heard me say that I was not going to be able to be in early because I had to go to the nursery before I saw him, because I never bring germs into the nursery. I always go to the nursery first and then go to the germy floors. And he was going to be going home that day. I walked in and he said, "Oh, thank God she's here." So I don't think there are many doctors that get that reaction in the hospital. Oh, thank God my doctor's here. But that's how excited people are to see you when you, I don't feel like I did that much for him, but to him it made a huge difference. So touching your patients, I think, is imperative. And I was joking with my mom. I knew it was one of my aunts or uncles that used to always say, he would always ask his doctor, did you graduate at the top of your class? And his doctor would say, Mr. Ferguson, it doesn't matter. They still call me doctor. So I know not everybody in here is going to graduate at the top of their class, though I know some of you will because someone in my class did. It was not myself, but I wasn't in the bottom either, so don't, still strive to be top. When I say top, I mean I wasn't 1 or 2. I'm not saying I wasn't 3 or 4, but no, I'm just kidding. Just kidding. And I think ultimately your patients know whether or not you care about them. So I think our hearts and our hands are probably the most important. If we don't know something, we can look it up in a book. If a patient asks me a question, give me a second, or I whip out my phone, right? We all have iPhones now, or Palm Pilots, or how things have changed since. I think about my oldest niece is in college, where I went to college, and now they can text each other, meet me here, and they have a coffee bar on campus. I'm thinking, how college would have been with lattes and cell phones. I don't know. Would have been so much different. Would have been so much different. But don't be afraid to say you don't know and look something up. I mean, we look stuff up all day long. I'm not embarrassed. I don't know everything. None of us do. I think about if when A.T. still founded osteopathic medicine, did he really know what it could be, like the potential? And we were just reviewing a study in our OMM Residency Journal Club, talking about different studies that show how manipulation can. There was one study in particular on pneumonia, and if anybody knows what I'm talking about and I get it wrong, just correct me, about pneumonia patients and how much faster they healed with osteopathic manipulation, even more so than antibiotics. But of course, doing the two together was synergistic, so it can do a lot to really increase the rate of healing. Hospitals love it because patients leave faster. We have a large new osteopathic hospital, I think 280 beds, give or take. And most mornings when I walk in through the physician entrance, there's a big sign on the door that says bed capacity alert because we're always full. Well, I think our hospital is pretty interested in getting patients out faster when they don't have an empty bed for anybody that comes into the emergency room. So that's another big deal. The study also definitely showed that patients are more satisfied with their hospital day when somebody takes the time to put their hands on them. And of course, decreased pain levels is another big benefit. No matter what specialty you decide to do, I think osteopathic manipulation can become a part of it. I don't, by any means, have on rose-colored glasses that everybody wants to do what I do. I love what I do, but not everybody probably would love what I do. But if you want to be a surgeon, great. We need surgeons, right? If we all did the same thing, it'd be really, really boring. I think the only thing I've had a hard time figuring out how you could really incorporate OMT into a practice is dermatology. So for those of you that want to do derm, good luck. I don't have anything for you. But surgery, post-op ileus, I mean, there was a time period when I worked with a doctor. She was a family medicine resident a couple years ahead of me. Her husband is a general surgeon. She would tell patients at the clinic I worked at with her, this is the doctor that can make anybody poop. Great title, right? But that's how some people knew me for a while. I was the doctor that could make anybody poop. And but it works. When I was a third and fourth year medical student in my rotations, my first rotation was surgery. I spent the entire day in that OR, but let me tell you, in between cases, what was he having me do? I was going around treating every patient because they were getting out of the hospital faster when I would put my hands on them and treat their post-op ileus or prevent their post-op ileus. And 5 minutes in the room. This doesn't have to be time consuming. It's not rocket science. It's just osteopathic medicine. So it's pretty easy when you just think about it a little bit. But I think you also want to think about how you'd want to be treated in the hospital if you were there. I think this might have been a quote from the dean at Michigan State. I'm not sure. I was reading a magazine, but it stuck with me. Ultimately, it doesn't matter how much you know. It matters how much you care, because we can look it up. And this, who's that, Matthew? Who is that? Marlo? Yeah. That's my newest niece. And I think she's pretty cute, so I have to put her in every... Like, when I do my baby cranial lectures, it's quite fitting, because I say this is how happy babies are when they get treated. And does anybody have any questions for me? I hope I didn't bore you too much. But that's baby Marlo. My mom told me I should have put the last picture as the end of the picture of her butt from her first birthday, because she had her name monogrammed on bloomers. But I didn't have a chance to do that. So.
Laura?
Foundation Osteopathy lecture. Thank you very much, and wish you Godspeed.